We're back at it with another House MD reaction, this time jumping ahead to season 6, where House actually confronts his use, perhaps overuse, of his Vicodin. But for this episode, I need some help from my friend, Dr. Eric Bender. Welcome to the show.
My name is Dr. Eric Bender. I'm a psychiatrist. I specialize in psychotherapy. I see children, teenagers, adults, and couples, and I do a lot of work with media, and I'm really excited to be here today.
Huge thanks to Grammarly for sponsoring this video. I'm getting a sense of withdrawal symptoms here.
Yes, absolutely. So at this point in the season and in the series, House has an ongoing addiction with Vicodin, an opioid. If you think of opioid use, you think of how things constrict, secretions, and pinpoint pupils, and everything kind of decreases. When you get off of the medication, you'll see sweating, you'll see pain, you'll see all kinds of discomfort, and that's exactly what we see here.
Yeah, so basically whatever symptoms you experience while on the medicine, almost kind of the reflex opposite starts happening.
Exactly, yes.
Uses of restraint in a situation like this during, it looks like a detox?
The restraint is somewhat unusual to me, unless he's made attempts to really harm himself, if he's punching the glass, if he's doing things that are really dangerous, maybe some restraint.
If I'm using restraints, we have very specific forms that need to be filled out, they need to be timed, they need to be renewed. There were times back in the day where people overused restraints and they were just putting them on without understanding how much damage they can cause, not just from a physical standpoint, but also from a mental health standpoint.
Dry heaves are gone, so am I.
I'll check with the doctor.
No. I'm here voluntarily. Just gotta check with me.
I'm sorry. Dr. Nolan left specific instructions.
Is that true that you can voluntarily check in versus court mandated or doctor mandated?
Yes, you can come into the hospital under voluntary conditions where you're saying, I'd like to check myself in. Now, you have to be evaluated to make sure it's appropriate for you to be there. And then there's the ugly side of this, is your insurance going to cover it? At the same time, if someone is a danger to themselves, a danger to other people, or they're so gravely disabled, we say, that they can't provide themselves with food, clothing, or shelter, then they can be involuntarily admitted to the hospital. But in the case of someone voluntarily admitting themselves, House is right. He can say, I don't want to be here. That might be against medical advice or AMA, and that's what they're referring to. Let's have the psychiatrist that has admitted you here talk with you about this.
Got it.
I am a lot better. No painkillers, no hallucinations. Like it hurts, but it's manageable. Great job. Gonna miss you. Want to start missing you as soon as possible.
Well, legally, you're free to go whenever you want.
Are patients in the space where they're using pain medications, are they counseled appropriately, you think, in terms of what the risks are of these medications?
I think these days, yes. In the beginning, not so much. That idea of, let's double your dose if you're having more pain. There were a lot of things.
Like we have to get to zero pain.
Yes.
Oftentimes was an unrealistic and perhaps harmful goal.
Yes, and I think medication, I even say this to patients with depression, anxiety, other mental health issues, medication is a part of treatment. It's rarely the only thing. So what else do you need in your life that helps decrease pain? It's not always pharmaceuticals.
That's always a good flag, because when I ask patients about timing of their pain, some will say, well, I have it more at this time in the morning or at night, or when I'm doing this activity, and that's true, I want that info. But a big part of it is, are you having it on weekends when you're not working? Are you not having it during weekdays when you're away from your stressful family? And those kinds of hints will allow me to tailor the questioning in a different way to better understand what's driving the pain. Because if someone has an anatomical injury, it's not gonna pick and choose days of the week when it's gonna present itself.
Yeah, and then I think you're referring to something we call somatic symptoms too. A lot of people feel stress and anxiety as pain. It's not me saying your pain is not real. That's how you experience some of these other emotional things as well, and you have a chronic painful issue too. It just happens to get exacerbated when you have maybe some emotional things as well.
But I suggest you stay.
I'll take it under advisement.
If you thought the hallucinations were from your Vicodin problem, why didn't you just check yourself into a rehab facility?
I was deluded into thinking I might be crazy.
But you had been abusing Vicodin for years. Never had delusions, never had trouble sleeping, never had any problems other than narcissism and antisocial behavior until 2 colleagues died.
Why do you think he chose to go into a psychiatric hospital versus a rehab facility? And what is the difference?
My understanding is that at first he checks himself into medical detox, essentially. This psychiatrist is telling him, I think you need to go into a psychiatric inpatient unit at this point to work on your other things.
What is a psych inpatient unit?
So an inpatient unit means that you're not living outside of the hospital like an outpatient. You're living in the hospital for typically a short amount of time. An inpatient stay is for an acute issue, something that's often, again, a danger to oneself, a danger to other people, where someone is so gravely disabled that they can't provide for themselves. So you have to work with that patient to figure out, is an inpatient the best, or is an intensive outpatient program where you show up in the morning and you leave at the end of the night better? You do figure out what's best for the patient.
Cool.
You need to be transferred to our long-term ward, started on medication, talk therapy.
Yeah, I get it. Just one thing I'm getting hung up on. I can leave whenever I want. How about I start with that?
You can't go back to practicing medicine. You're going to need my recommendation.
Can that happen?
It can happen that a psychiatrist or another physician can say, I'm not sure that my colleague is fit to treat people. So if the doctor seems way out of it or seems like they're not thinking clearly because of maybe a mental health condition, someone could say, I'm very concerned about this person practicing, and you might need a letter to reinstate things.
Yo, everybody! This is my new roommate house, y'all. Main thing you gotta know.
Is this a line?
Hey, Gabby! Meet my new roommate house. You can call him Heezy.
No, you can't.
Don't worry, she won't call you anything. She hasn't talked in like 10 years or something.
Where is he now?
There are things in mental health called long-term care facilities. It's different than inpatient. In San Francisco, for instance, there's a place called the Behavioral Health Center, where it's a long-term care facility. Here, it's something similar, where people are staying for long-term stays because of ongoing chronic mental health issues.
Now, something I've always wondered, does it become more complicated when they're living in a community full of other individuals that are also struggling with their mental health? Or does that help in some way?
I think I have the belief that connection with other people really helps, and that's a big theme in this episode too. And I do think people can learn from each other, and we relate to each other. So there are systematic things that happen here that show that they can function in community, because when you leave, you're actually going to be in some kind of community, just a greater community at large. However, there can be times when someone can influence another, and perhaps there's not good things that come from that.
If anything else, it teaches flexibility and adaptation, which you're going to need in the real world, because there sometimes be mean people, sometimes nice people, and you never know what to expect, and you have to be comfortable in managing
Exactly.
your response to that stimuli.
Correct. Yeah.
We can't play that, they keep it locked up. I wish we could, but at the same time, you can imagine how annoying that could be. Crazy people playing on it all the time. We'd never get any peace.
They've used the word crazy quite a bit already in this episode. What are your feelings on the word and what they're trying to show here?
I think what they're trying to show here are that the patients are aware that's how they're seen. So the word crazy, I don't like to use it. Sometimes I'll use it with patients and saying, I think you probably have this feeling like you're crazy, but using it in that colloquial sense to say, I know how people might refer to you and how you might be feeling.
She's my husband's sister. See her head? She bobs to the music. It's the only real reaction I'm getting from her. Feels like we were talking.
You're not talking. Her head is bobbing to her pulse.
Are you a new doctor on the ward?
Technically, yes.
What do you think is going on with that catatonic state there?
Catatonia is a state where people sometimes don't move, or you can have different types of catatonia. You can have a waxy flexibility where you can hold someone's arm up and they hold it like that. Sometimes medications can make people catatonic. In this case, I don't think that's what's going on with this patient. Sometimes people have a reaction to severe trauma and become catatonic. There's some kind of trauma, there's something going on in her background, and we don't know what it is.
See how they give you a ping pong table, but no paddles, no net. It's like they're mocking you.
Preach!
Whoever saw a tennis court without a net?
All right, why don't we just go and sit down and discuss it?
No, I want to discuss it right here.
House is right. I think everyone here can handle these.
He's standing up for his, and they're not colleagues or not mates, I don't know what they are. Co-patients?
Yeah. What I really like about that is when Dr. Nolan comes in, it's like, yeah, I think you can handle these. It's a good point. So he listens, he can see that they want this. And again, that idea of being seen, being understood, that's really what I think is the connection.
I'd like you all to welcome another new addition to our ward. Steve.
A Freedom Master. Steve Alkertine's just a cover. It's like Clark Kent or Bruce Wayne or Peter Parker.
Cool. We get more Jesuses than superheroes.
Well, I try to blend in the outside world, but I figure in here, everybody gets it.
So this is like a group session that they're
Yes.
having? Yeah. And what's supposed to happen in a group session?
I think even on an inpatient unit and on this in this setting, the idea is this is community. There are other people here. Let's understand how people react to each other. Let's understand how to speak to each other, what's okay, what's not okay. Each person is a different thing.
So it's like a more controlled communal environment.
Way to relate to each other in a communal environment.
How are you feeling today?
Better than yesterday, not as good as tomorrow.
And is that typical of how medications are distributed?
Sometimes people will come up for a line, or somebody might bring medications to the person's door or something like that. It really depends on the staffing and what the policy is. What's interesting here is I don't know why he wouldn't be taking something. Like, what are they giving him that he's not trying to take? Because if he's taking anything for detox still, he'd want to take that.
Yeah.
And he's not behaving in ways that suggest he would need something, unless maybe it's an antidepressant medication, which can decrease aggression sometimes.
Do they check that you take the medicine usually?
I was going to add, so if there is a patient that you suspect is cheeking, you can do a check.
Is that what
make
it's
sure
called,
that-
cheeking?
Cheeking,
Oh,
yeah.
I've never heard that.
Yeah, cheeking. If you think somebody's cheeking, you can ask to examine their mouth. Lift up your tongue, stick it out, please, say ah. So not because we're punishing you, but we really think this is what's good for you.
You're not having any side effects from your meds, which is unusual.
You don't trust me. Actually, it's more fundamental than that. You don't like me.
I didn't say that.
You think I'm not taking my meds?
Are you?
Yes. So what do you want me to do? Want me to take a urine test? Will that earn your trust?
Actually, yeah.
The only scenario that we do this in a primary care outpatient setting is we do have controlled substances agreements. So if a patient is coming in and we're the primary prescriber for a controlled substance, we will create an agreement where we will decide how often refills are done, what would happen if medications are lost, for what period of time they're prescribed, how many number of refills, if there is ever a need for urine drug testing, how will it happen,
Yes.
so that there are no surprises and it doesn't feel like anyone's attacked, because this is just a universal policy.
Exactly. And when I have had urine toxes for patients, for medications, it's typically because an organization requires it. So if I see professional athletes, they're going to have a urine tox not only for illicit substances, but if a professional athlete is taking a stimulant medication for ADHD, then they might have a urine test where that shows up, and it shows the professional organization they are taking their medication as they're supposed to.
What do you think about the interaction with the doctor in general? It seems like they're kind of a bit antagonistic.
They are. I don't like to have antagonistic relationships. I think you can be more direct, and he could say something like, well, what if I didn't like you? What would that mean? I don't know that you're taking your medication. The way you're behaving suggests, I don't know. It feels a little uncomfortable to watch.
Have at it.
A little dignity, please.
You know the rules. I have to watch.
Yeah, but you don't have to have courtside seats. Can I at least use a stall?
Is that true that they have to watch if they do it?
It depends, but yes, a lot of times there's somebody watching.
He's gonna mix in some meds there. Oh my God.
That's highly unlikely. This is unusual to have somebody else, but people go to all kinds of lengths. Sometimes you see people using a fake prosthetic and they've carried in urine. On a long-term ward, they're probably not going to do that. But in certain situations, you might see that, or you might see urine hidden in a cabinet in a bathroom, and they do that. So there's all kinds of ways people try to get around this.
Sorry I doubted you. Freedom Master, think you could help me out?
You need help?
Could you move the piano for me? 500 pounds, it's not too much, is it? I just want to move it away from the window.
I'm sorry, my powers aren't
Just
for frivolous.
one quick lift.
As a doctor, what are you doing?
Either he is Freedom Master and he shouldn't be here, or else he's suffering from a serious and dangerous delusion that he needs to deal with.
Again, very antagonistic
Yeah.
approach by this doctor of wanting to disprove as opposed to building upon the premise and asking what impact it's having on the patient.
There's something called exposure therapy where you gradually expose people to things that they are anxious about. And you continue to expose them until the anxiety levels come down. But you work your way up to what would be most anxiety provoking. So threatening this guy's identity would be probably at the top. So you'd work up to that, and you would not do that in a public setting.
If someone has a delusion in a scenario like this where he says, call me by this name, I'm a superhero, I can do all these things, how do you approach that while being respectful and trying to, I guess, initiate a potential challenge so that the person can feel more in touch with reality?
What I would do is I would call him by his name. I would not call him out of a group. I would not put him on public display and try to humiliate him in any way. In individual sessions, I would probably try to say, tell me more about this. When did you realize this was your identity? How did you first understand this? You work with people where they are, especially in a long-term care facility where you're not limited to a few days or weeks. This could be weeks, could be months, could be longer.
What is she looking at?
You're not a superhero, Stephen. You're just a regular
save her.
person. That's okay. We're all just regular people. It's what we do.
They
with that
stole her
power.
voice box. They have it in there. That's what she's staring at. That's what she's staring at. She's always staring
Your
in there.
wife
because-
is dead.
This feels like a bad Shakespearean play playing out in real life.
I don't, when somebody's wife has died, it's so traumatic. Why would you announce it that way? Why would you use it as a weapon to tell him you're just traumatized and you're trying to pretend to be the savior? He's probably gonna be aware of his own reactions. He's the superhero. He's not supposed to show emotion in his mind, probably. He's probably also imagining he's the superhero because if he had been a superhero, he could have saved his wife. And I think that's what this psychiatrist is trying to show, but it doesn't work.
Her voice is in there. Her voice is in there.
Kelly Gray.
Her voice is in there.
I don't know, again, that they need to pull him away from
I feel like this
that.
was created by the doctor here, as
Yeah.
opposed to the patient creating
Yeah,
this.
exactly. The doctor could have said, hey, I see you're upset. Why don't we try this again? Can we go have this conversation somewhere else? And now if it escalates,
Yeah,
sure,
exactly.
you can bring it in.
Did you drug him?
Of course I didn't drug him.
He's a flat affect. He's practically catatonic.
Hey, we got cake.
He's fine.
Double chocolate, yummy, yummy.
Don't tell me that he's fine. You did this. He was functioning. He was happy.
He was delusional.
Yeah, he's way better off now.
It seems like they're trying to stage this doctor war between pharmaceutical treatment and actually talk therapy.
Well, it's funny you mentioned that. In the 90s, there was that kind of a war in psychiatry treatment. And here, I think what they're trying to do is actually show that this doctor has given this patient too much medication. House is sensing he's been punitive. He's actually tried to punish this patient in some way for not listening to him, which again is a good thing to stand up for, whether House is standing up for the patient or just proving a point. But I do think more than the war between meds and therapy is the war between this doctor and House and this patient.
Back to House in just a second, but first, I want to tell you about Grammarly. It's an AI writing partner that helps professionals with all their writing needs with high quality and personalization. So it sounds like you, not AI. If you've been watching my channel for a while, you probably noticed I'm uploading a lot more podcasts lately. While these conversations have been truly satisfying, it has forced me to write a lot of scripted intros for each guest. This is where Grammarly's AI tools have been super helpful. I can brainstorm with the AI chat on the perfect way to intro each guest. Grammarly can provide me with tons of suggestions, particularly with the Humanizer tool that can really make sure my writing doesn't feel too robotic. And of course, I'm most concerned with the audience's response to my writing, which is why I've become such a big fan of readers' reactions, which predicts questions and confusion you might have based on my current draft. Grammarly then suggests revisions to improve clarity and get me to a final draft sooner. Level up your productivity and get Grammarly today. You could use my link for 20% off Pro. All right, let's get back to House.
I'm coping better than you think. I've not been taking my meds. Not one. And yet, I still scored high functioning in your depression test.
So your proof of your well-being is that you lied?
Manipulated.
Well, the test is just asking you subjectively how you feel. Are you fooling yourself by
I know,
doing
yeah,
it?
yeah. He's trying to manipulate the system. He's doing anything he can to get the letter. Get out, get out, get out, get out, get out.
The hardest part for me as a primary care doctor with mental health conditions is what to do when a patient is unmotivated or perhaps doesn't want help. And this kind of falling into that scenario. What can one do as a provider in scenarios like that?
And I think they're actually showing, I think Dr. Nolan is doing, he's talking to him, being, do you realize any of this? So you're saying you're better because you've learned how to lie and manipulate. So you try to help somebody see the patterns of their behavior and how it's affecting them. Is it serving them well? Is it not serving them well? What does serving them well mean? And at other points, if this were not a medical licensing issue, I would say to somebody, I don't know how therapeutic is it for you to come to therapy, to be forced to be here, feel like I'm the one who wants you here, when really this should be for you. But in this case, he's not got that option because he wants to keep practicing.
These are your pills from today?
I'm not gonna take it. I'll just cheek it again.
Lick it.
What?
You want me to lick your hand?
I washed.
Is he giving him sugar pills?
Yeah.
It's sugar.
Is that ethical?
No. In fact,
Flat out no.
in fact, I had a colleague recently, she was consulting on an inpatient psych unit. I was like, well, can't you just give the patient the medication, tell them it's a vitamin? No, we can't do that. It's not ethical. Unless you actually get consent to say, we're going to try some different things with your medication. Some days we'll give you a placebo, some days we'll give you this. So if they can be part of the treatment, yes, but that's not ethical.
Why are you so nice to me?
I think you have a good heart.
Would you still be nice to me if I told you that I lied? I'm not just driving around the grounds in your convertible. I'm kidnapping him and stealing your car.
Just to be clear, the reason he's doing this is that he has gotten privileges to leave. So when you're in a long-term care facility, you do work up to getting, okay, you can have a pass for 2 hours. Okay, you can have a pass for this many hours. That's why he's outside. Some people might say, what is going on here?
Yeah.
Sure. It's just starting to feel a little heat between us. Thought we had kind of a Bonnie and Clyde thing going there.
Bonnie and Clyde get shot to pieces.
See ya.
I try to put myself in a viewer's mind in a scenario like this, and I could see how in their mind they'll say, oh man, look at that other doctor was giving him medications when all he needed was to fly. And that's a very oversimplistic and incorrect view.
It is an incorrect view. What I would tell audiences they can consider taking away from this is that not all therapy, not all bonding has to happen inside the office. So I've had a patient, for instance, a young woman had a heart attack. I would meet her at a park and walk around with her because that was a better environment. I'm not going to take somebody who thinks they're a superhero to a park and do outdoor / what would be indoor skydiving.
Yeah, okay.
That was the coolest moment of my life. It was fun. You can repay me by telling Nolan he's an idiot.
You can repay him by telling Nolan he's an idiot. That's why he wanted to do this. He wanted to prove this doctor was wrong. When it's not about the patient, it's a problem.
Careful of the traffic. Don't go damaging any fenders. Hey, come on, get down.
I would play dead. Act like I'm a victim and I need help and I've hurt myself. Because in this delusion, it seems like he's wanting to save.
Yeah, I mean, that would be good thinking, and that's a lot of psychiatry is improvisation. So yeah, maybe you play dead, you scream, you do something like that, say there's something wrong.
Thank you, Greg.
Oh my God, this is the darkest episode of House MD. I did not expect that.
He's lucky to be alive.
Oh.
He's got a lacerated spleen, rotational pelvic fracture, compound break of the femur and humerus.
That's a serious injury there.
Yeah, it is.
Lots of bleeding with a ruptured spleen and all those fractures. A femur fracture is notoriously hard to get because the femur is one of the strongest bones in the body, if not the strongest. Uniquely, some medical situations that can arise from that is you can develop something known as a fatty embolus, where literally a piece of fat starts entering the venous system of the blood supply and can cause a plug and therefore be lethal.
I'm transferring you to Winslow Psychiatric. You'll have better luck pulling the wool over their eyes. I'm done.
Do directors just say, I'm done with you?
I think with somebody very narcissistic like that, there are people that will say, I'm done. Like, you've caused so much danger, so much havoc. There are other people you can go see. You should do that. Legally, there are some steps you should take.
Like a 30-day period,
give them a certain amount of time, give them names, all that kind of thing. But at this point, this guy knows exactly what he's doing, and the attendings, like, he's not a danger. He's not gonna find some harm from being cut loose from my practice. Just let him go.
Yeah.
Don't. I need help. I've had a billion things happen to me in my life. How am I supposed to know which ones are relevant?
As far as I'm concerned, they're all relevant.
Well, we better get moving, because this session could take 50 years.
Yes, you are the sum of everything that's happened to you, and yes, some events are more relevant than others. But the only way we can figure out which ones are is to talk. So tell me, what's on your mind?
It's funny that he's talking like that, because I often open my sessions. If patients don't come in and start talking, I'll say, what's on your mind? How are you feeling? If we do zoom out, I think culturally men have been taught to swallow feelings, not talk about them. It's weak to do that.
Yeah, I see that happen quite often in my practice when they come in for a physical ailment and I start moving the conversation to a psychological frame of mind, and they are very resistant and reluctant.
Yeah, I've had patients tell me, professional athletes especially, will tell me things like, I'd rather have a broken arm than have to talk to you about this stuff.
So now, all we have to do is figure out how to get you from here to happy.
SSRIs? That's your genius technique?
I don't think we should ignore any tools that can help.
SSRIs can help with a lot of different things. It can help with decreasing aggression. It can also help with emotional regulation. So I think that's what he's going to try to convince him to see.
I know you don't have a problem taking drugs.
For my leg. For pain.
Well, think of this as being for psychic pain.
I don't want to change who I am.
Miserable?
I get that a lot. I don't want to change who I am. And I'll tell them, if this makes you somebody you're not, it's the wrong medication. I have no desire to change you into somebody you're not. But I do want to help you feel better.
Van Gogh was your patient. He'd be satisfied painting houses instead of the starry night.
Van Gogh would still be making inspired paintings of the night sky. Just maybe not from the room of his asylum.
You don't know that.
I know both his ears would be intact. And I know his life would be better.
You don't know that.
Well,
you can hope for that.
Yeah, you can hope for that. You don't know, but I operate in the same way where I think connecting with somebody, understanding them, giving them a space to be who they are, to talk about things they probably haven't talked about, to think about things in ways they haven't thought about, can be helpful. And I really think that's what he's saying. Like, maybe Van Gogh wouldn't have cut off his ears.
Yeah, and maybe Van Gogh would have made different art, but it would have been even cooler art.
Exactly.
You just don't know.
Exactly.
I know this doesn't come naturally to you. But you want my help. Which means you need to trust me.
This doctor is becoming demonstrating a high level of empathy here. Do you ever develop compassion fatigue?
I don't, but what fatigues me, I really want to focus on my patients in the 50 minutes, and I see back-to-back patients. I get tired because I'm just trying to focus, and it's very individualized. I'm not doing a generic thing with everybody. It just doesn't work that way. What happens for me at the end of the day is not compassion fatigue, but just listening fatigue. At the end of the day, saving enough for my family to be able to say what was going on in their day and all that. Because what will happen is they'll say, "How was your day?" I'm like, "It was fine." And that's it.
Yeah.
I want you to trust people. Try.
That is a big issue I see in people, particularly people with a lot of trauma, is they have a really hard time trusting people. People with what's called complex PTSD. It takes a lot longer than just a couple days to be like, oh yeah, try. Because there's a reason that people don't trust people. And sometimes it takes me a long time with patients to get to that point of them realizing they don't do that. And I'll have to comment on what it's like to relate to them. So this is a very brief way of introducing the concept, but what would unfold in therapy would be a little bit different.
Just open up. Trust.
That's like saying just chill out to someone who's having a panic attack.
Calm down.
Yeah.
Don't worry about it. Like that's a little egregious, but I get what he's trying to do. It just would look differently in real life.
You asked me why I come here so often to visit Annie. She was my best friend. I think I married her brother because he was the only other one who was going through the same thing.
A little trauma bonding?
Yeah, that term does come up, trauma bonding. Someone who goes through something really difficult, someone else is going through the same thing, they understand each other in a certain way.
This is a bit of a forbidden romance happening.
Yeah, I was thinking this is very highly problematic for a patient on a long-term health facility. I don't know what would happen because I've never experienced that, but I think it would certainly be addressed and say this isn't healthy for people involved. And
is there a world where it is healthy?
No, not that I can think of.
We kissed each other.
And how do you feel about that?
How do I feel about that? It was a kiss. Kisses are good things.
Okay.
That was a loaded okay.
Not at all. Why would you assume that?
You're being judgmental. If I'd said that I had some delicious Chilean sea bass for dinner last night, would you say, and how do you feel about that?
If the sea bass was married, I might.
That's a good line.
Yeah, it is. What I think is good here is Nolan's matching house in wits. You have to have some buy-in from your patients. So if they need you to be somewhat on the offensive at times and it benefits them, but you're not hurting them, then I think that's okay.
Why do you value your failures more than your successes?
Successes only last until someone screws them up. Failures are forever.
So you accept that fact. You accept that there's nothing you can do.
Okay, I accept the fact that there's nothing I can do. Now, what can I do?
You acknowledge failure and you move past it.
He's being very direct here. Is that
It can be a style of therapy for sure. I think House operates in a direct way. So I would say something like that if it's a patient like this.
Yeah.
If it's somebody else, no, it doesn't fit.
You're not just doing that generically.
No, not at all.
Get someone to jump off a building. You say 2 words and you move on with your life. Hardly seems fair.
Is that the issue? You have to suffer equally? You're not God House. It's just another screwed up human being who needs to move on. Apologize to him.
In doing this type of therapy, there are so many moral, legal, cultural things that need to be taken into consideration. How does one balance what is right to do? Like, he's like, the right thing to do would be to apologize, or whatever statement he's making there.
I learned that by observing the patient and understanding them and having them tell me about their family culture and what they think. I learn about their choices, and I learned that along the way. I wouldn't say it's the right thing to do to a patient. I would say, what would it be like if you considered apologizing? How would that feel? If they're like, well, that would be wrong, or that would be right, I'll say, what's right about it? What's wrong about it?
So you want them to be more reflective?
I want, yes, it's so much better to have it come from them than for me to say it.
Diane, maybe you and I can work together and figure something out.
I can save him.
They stole her voice box. That's what he said. That's what she was staring at. That's why he's staring.
Dr. House, please.
Because there's a music box in there.
Orderly.
Come on, just give it to me. I am not having a psychotic break.
This seems like he's having a psychotic.
Well, it's just funny that earlier when the guy was trying to
Yeah.
get this music box, they came and took him away.
Yeah.
So psychotic break is actually when you have this disconnection from reality. You might be hearing voices or seeing things that aren't there. Your thinking might be all over the place. He's trying to get their attention. He's trying to say, look, no, there's something we should think about.
This is what you wanted. If you thought you could cure Silent Girl with this, just by your own rationale, it should cure you. There's nothing wrong with you. You're healing. All the parts work. Speak. Come on, speak. Say something.
I think maybe everyone should take a break now.
Yeah, hands on another patient's not
Yeah.
not okay. I think still this shows House is doing this for himself.
What a great acting gig. Hey, we're gonna hire you just to stand a bunch and sit and then open this box.
Thank you.
Dramatic.
Yeah, a little dramatic.
Yeah.
I don't know that I'm
Not that it would, there's no like instant cure, right? Is that
correct.
what?
And I think the message is that
oversell here.
even love or even a loving moment isn't necessarily going to cure catatonia.
This is the problem with medical dramas, in my opinion. It creates a false understanding because most people watching this are like, oh, well, it's that simple sometimes. So everyone's searching for their music box.
Yes, that's why I'm writing medical dramas with the right,
Yeah, exactly.
appropriate perspective.
Sure.
Yes.
I don't want you to go.
I don't want to go. But I can't break up my family. I can't leave my children. I have to go.
She left. And I'm lost.
I'm going to write your letter to the medical board recommending that they give your license back.
You can't just console me by giving me a lollipop when I skid my knee.
Look, two things just happened. You got hurt, which means you connected to someone else strongly enough to miss them. And more important, you recognized the pain and came to talk to me instead of hiding from it in a Vicodin bottle.
That seems like a good analysis.
It is.
Yeah, for the
It is.
first time in a little bit.
I see patients who have addiction issues, and a lot of times what they're addicted to is covering up their feelings, covering up their emotions. So to be able to come to somebody and talk about it instead of going back to Vicodin or alcohol or cocaine or whatever it is healthy.
Today, we're here to congratulate Greg. We're proud of him, we wish him well, and we hope to never see him again.
Is that a thing that people say?
I have not seen this. I think I mean, there's some bonding.
Please leave now.
Yeah. But I get the sentiment. Sentiment is we want you to succeed. We want you to be out there in the world. We want you to have the experiences you want and to be healthy.
So, scale of accuracy from the psychiatric component here.
I honestly think they did a pretty good job. With some of the things we talked about, I'd say they're closer to 7, 8, to be honest, somewhere in there.
Yeah, for shows where the medical accuracy sometimes starts straying into the complete unknown, this was, it held pretty true with some dramatizations that perhaps made it less realistic, but overall, I feel like the message was pretty good there. You know, doctors sometimes can be pretty ruthless. Click here if you want to check out a video of some awful things doctors actually said to patients. Huge thanks to Dr. Eric Bender for coming on the channel. His channel is linked below. Click that, check that out as well. And as always, stay happy and healthy.